a large parterre of speakers talking to us what's in store for ICU. I'm here to coordinate this session with Elie Azoulay from Paris, France. My name is Claudio Sandroni, and it's my pleasure to introduce the first speaker, Professor Massimo Antonelli from Rome, Italy. And the topic will be mechanical ventilation, respiratory insufficiency.
Thank you very much for the introduction. To be honest, I do not know if the session, at least my presentation, will be so treated. And maybe someone of you may feel disappointed with my presentation. However, I didn't want to go into hyper-physiological details or new researchers, but maybe my presentation will be slightly more philosophical. These are my conflict of interest. Well, I asked myself, what could be the future? It's a beautiful movie, a science fiction movie that came out at the end of the 90s. Remind me something. You can see over there the two protagonists, Robin Williams and Sam Neill, that were lying on the bed in the final moment of their life, and they were fully controlled by an external energy and computer without any invasive monitoring or without any invasive thing. Is it the future? They were indeed even assisted to breathe. And the nurse there was using something very sophisticated. Maybe a quantum computer for the future, I do not know, but something like this may represent a further option for the future. Or AI, the artificial intelligence. We have spoken so much during these days about the application of artificial intelligence to the various fields. But my question is, does it work? And if we look at what has been published up to now, we have some interesting clues. For instance, in this paper that included more than 20,000 patients, the authors just focus on the use of artificial intelligence to predict prolonged mechanical ventilation and the eventual need of tracheostomy in these patients. As it happens in the artificial intelligence and the big data situations, then they inputted into the platform a number of information, in large part looking at the severity scores, looking at the physiological variables, as well as all the comorbidities presented as a number with percentage in this table. Well, they finally, at least in this publication, were capable to demonstrate that the use of artificial intelligence and machine learning for the early identification of this category of patients who may be more prone to have a prolonged mechanical ventilation and tracheostomy, showed a real effectiveness. And so something that apparently can be easily applied. In a new publication, again, in the environment of mechanical ventilation and infections, lung infections, another group focused their attention on the matching of subjective severity assessment on pneumonia and the prediction in terms of need of mechanical ventilation. This is a core study, for sure smaller than the previous one, but the authors combined together the radiological score with physiological and clinical variables. Interestingly, you can see here the sensitivity and specificity under area curve, and are quite good, 0.83, 0.71. And the author concluded that those patients who were on ventilation had significantly higher radiological score and artificial intelligence score than those that were more prone to recover and without the need of mechanical ventilation. What they have done, just adding some very relatively simple parameters such as the age, gender, white blood cell count, and the peritoneal oxygen saturation, reaching a prediction that it seems to be interesting. 0.86, 0.8, and 94, together with the RAD score. And then this could be another proposal saying, okay, this is a robust indicator and can identify easily the adverse outcome of these patients, just preventing them and focusing on the population. But there is always a but. Looking at the recent meta-analysis published a couple of years, last year, by the group coordinated by Luigi Camporota and Gallifant, they approached the artificial intelligence applied to mechanical ventilation, just preparing and elaborating a systematic review, reporting standards and biases. The studies included in these analyses were 95, and unfortunately, the vast majority of these studies, for at least one of the parameters that should address the risk of biases, has indeed at least one high risk of bias in any particular of the investigated categories in terms of device into practice model, algorithm into model, and mathematical algorithm. And the authors finally concluded the artificial intelligence applied to mechanical ventilation as limited external validation and model calibration with substantial risk of bias, significant gaps in reporting, and poor code and data variability. So, despite the potential utility, for the moment, it seems that something doesn't work as we expected. So, what can be the alternative? Maybe something that you have seen several times during these days. Identifying subtype and subpopulation where to apply the technology of the artificial intelligence. Here, coming from the big group of the Isicem on the of the LungSafe study, were identified, thanks to the tight collaboration with Karen Calafee, and hyper and hypo-inflammatory patterns, looking at the different mediators, and finally identifying two different trajectories in terms of survival, looking at a hyper and a hypo-inflammation. So identifying a population where, analyzing the various variables, you can at least focus better the attention and personalize really the future therapy for them. Yeah, another example may come from the study focused on COVID with more than 1,000 patients, and where in the Netherlands we're capable to trace, Lubos is the first author, two different phenotypes, combining together once again the biological parameters, let's say, together with the physiological ones, such as respiratory compliance, PO2, VO2, and so on. And they identify precise trajectory over time of these two different phenotypes, looking at the clinical parameter, ventilatory ratio, PF, mechanical power, or respiratory compliance. And these obviously gave us further possibilities where the application of the artificial intelligence may be valid. And the same maybe was true for what we have done in the Italian network on the pathophysiology of the COVID-19, and where analyzing the dimer and the compliance, we could identify 4 different categories where the outcome was clearly different in terms of survival, and where the low compliance and higher D-dimer levels corresponded to the poorer outcome. And once again, also in this setting, applying a platform that exploits solid data in specific population with the artificial intelligence may be an option. Which are my conclusions, so we can give a large body to the discussion, that the future management of critical illness respiratory support still remains uncertain, and the direction of management evolution is still unclear, but physiological studies, which is another story. The artificial intelligence and quantum computers may theoretically help, but are still at their infancy phase. Don't forget that. We are just having a large and important hope on these possibilities, but still maybe are a bit premature. We need to gain experience and going better deeper into. And however, they may be helpful for identify the RDS or acute respiratory failure phenotypes, even though no biomarkers or physiological variables per se represent to be so reliable for being a universal indicator, such as the famous Holy Grail. And the identification may also imply a better and different and personalized therapeutical intervention. But I want to conclude with my final consideration, that the physiology still counts. We live in a world where the randomized trial seems to be the gold standard. But please don't forget how much we have learned by the physiology up to now, and what we do, at least in the field of mechanical ventilation and in respiratory physiology, it's all based upon the shoulder of giants who never conducted a randomized trial, but analyzed the phenomena and try to interpret them. So the physiological principle may serve also for the future, or must serve for the future, as the foundation of the designing meaningful trials based once again upon physiology. Thank you.
Thank you. Thank you, Massimo. Really, really interesting. I would like to start with one question first. So, computers are capable of managing a large amount of data, right? And they can do that exceedingly fast. Do you think that the problem is not that their capability to manage these data, but to put these data into context and use properly the algorithms to use it? So, because my impression is that the artificial intelligence cannot help until it will be capable to replicate the algorithms we have in our mind. They are very, very complex. What's your thought about that?
I think that what you are depicting can be synthesized in the aphorism, garbage in, garbage out. It depends on what you put in, inside the artificial intelligence platform. If the variables and the indicators make sense, is it much more probable that in the very end they will come out with something valuable and usable at the bedside. Otherwise, we'll have something very fancy research, maybe well published, but often not usable in the real life, real clinical life. So I think that the identification with several other, as I try to show, with several other studies, can be combined with the new development related to artificial intelligence in order to achieve a more reliable goal.
Okay, thanks. Any questions from the audience?
Thank
Okay,
you
if
very
not,
much.
we can move on. Thank you very much,
you.
Massimo.
Thank you, Massimo. We are now moving to the second presentation with the future of hemodynamic monitoring with Professor Xavier Monnet from the Paris University.
Thank you very much, Ali, and good morning. For this presentation, I disclose my conflicts of interest with Pulsion Medical Systems and with Göttingen, and with Baxter, I'm sorry. Hemodynamic monitoring, a few years ago, the only monitoring devices were for heart rate, plethysmography, blood pressure, and we had the old invasive pulmonary artery catheter. But hemodynamic monitoring is a field where technological progress has already led to the development of many new devices providing more variable, sometimes less non-invasive devices. But what is the future? Of course, it's always risky, and I will not play clairvoyant, but I think a good way to answer the question may be to ask, if we think of the future, what would be the best monitoring device we would like? I dream of a device that would be non-invasive, perhaps, accurate for sure, comprehensive, that would allow a comprehensive analysis of the patient's condition, easy to use and intelligent. Non-invasiveness is already a mantra for hemodynamic monitoring, as you know, and many of the new monitoring devices that have been developed are already non-invasive. And today, launching an invasive cardiac output monitoring device would be as building a car that consumes 20 liters per 100 kilometers. So non-invasiveness is a goal, and likely we will go on this path. We already have some non-invasive devices, bioreactants for cardiac output, volume clamp methods for cardiac output or arterial pressure. But this could be even more miniaturized devices. A few years ago, Michard and Sassler have reviewed already these patches that can be pasted on the skin and that measure some quite standard variables, heart rate, respiratory rate, arterial pressure, just with patches. It could be even cardiac output. We have now a new device which measures not cardiac output, but carotid blood flow. You see, just pasted in front of the carotid artery. It measures the carotid flow. It may be useful to test response to tests of fluid responsiveness, for instance, so a non-invasive estimation of cardiac output. It is possible that the most invasive devices will be replaced by miniaturized devices. For instance, this is a device, a very small device, that can be inserted in the pulmonary artery to measure the pulmonary artery pressure. And this is a remote monitoring for outpatients in cardiology. I'm not sure it will come in the ICU, but in cardiology you can find many studies showing that this continuous monitoring of pulmonary artery pressure leads to a lower rate of readmissions in these patients with chronic heart failure, miniaturized devices. Blood pressure is, of course, the most interesting variable we have, and again today we have some non-invasive ways, means to monitor cardiac arterial pressure, but in the future we may have even smaller devices. Thanks to new materials and flexible electronics, we have such devices. They are far from the market at the moment, but that you see pasted in front of an artery with measuring the piezoelectric waves, measure the arterial waveform in a quite reliable way. They even detect the dichrotic notch, which opens the possibility for monitoring cardiac output from pulse contour analysis. We can even estimate some more complex variables than arterial pressure, and this may be particularly possible by using very basic variables analyzed by artificial intelligence. In hemodynamic monitoring, AI may help us improve the measurements, for instance in ultrasound, I will not speak about that, but also assess some variables that usually require an invasive device. Look, in this study, for instance, the authors analyzed the response of just plethysmography to a Valsalva maneuver. And through a machine learning algorithm, they estimated the pulmonary artery occlusion pressure measured by the PA catheter. Another study showed that it's possible, again through AI analysis of very basic variables, to estimate central hypovolemia. I don't enter into details, but it was here just by analyzing electrocardiograms. So possible to estimate in a non-invasive way many variables. Nevertheless, these devices need to be accurate, and for the moment, and it's likely a very important point, the less invasive the devices are, the less accurate they are. Invasiveness is the only way to have an accurate measurement. If we think about the finger cuff method for measuring arterial pressure, so that is today on the market, the reliability is quite poor, reviewed here in this meta-analysis of Antonio Messina. In the large majority of the study, the accuracy for measuring cardiac output was not acceptable. So you see that the challenge in the future for these new devices will be to be not only non-invasive, but also accurate. Hemodynamic resuscitation is basically for improving not cardiac output, blood pressure, but tissue perfusion. And today we assess tissue oxygenation and aerobic metabolism with the same variables for years. We may assess tissue oxygenation, for instance. This is a Foley catheter, you see, that measures urethral perfusion. Not sure it's very interesting, but in some studies, like this one by the team of Alexandre Houston, they used it to estimate the effect of a goal-directed fluid therapy. Perhaps more interesting, we today have some devices, a device at least, measuring the mitochondrial respiration. I don't tell you how it does exactly, but you see that under such patches, it's able to measure the mitochondrial activity that decreases during a brachial cuff inflation that is properly inhibited by cyanide application. It's not on the market for the moment, but perhaps we may have such devices investigating tissue oxygenation in a deeper, in a more comprehensive way. Microcirculation is definitely, you all know, an important pathophysiological variable, especially in sepsis. But the big problem, as we acknowledge in this consensus conference, it was a few years ago, is cumbersome. It takes hours to analyze images and has many artifacts. And we already said that where we should go should be to an automated measurement. But this is now possible. There is a device that is, by the way, presented on a booth at this Congress, developed by Hyun-Inche, that allows this automated measurement of microcirculation. It should be launched on the market next year. And you see that it may open the possibility to monitor microcirculation eventually at the bedside. Of course, we need easy-to-use devices, and one of the progresses that may come very soon is wireless devices that will allow us to avoid this, sometimes it's called the spaghetti syndrome, you know, with the tubes, wires, etc. But perhaps more, it's not only an aesthetic issue, it's these devices may allow the remote monitoring of patients out of the ICU, in the wards, after the ICU, after the operating room. And a proper comprehensive analysis of all the variables may allow an early detection of deterioration of these patients. In hospital, cardiac arrest is really an issue. These are already old data from the UK. You see the rate of in-hospital cardiac arrest that often occur in the wards. And you see that they're usually due to the deterioration of very basic variables, hypoxia, arrhythmias. And so one of the possibilities offered by AI is to predict deterioration of the patients. This is predictive analytics. And likely you know that we already have some algorithms using very basic variables that predict clinical deterioration of patients in the wards. In the wards, by the way, there are breaks to using these devices in the clinical practice. There are many false alarms, and there is a big issue with the responsibility. One nurse for 30 patients in the wards, who monitors the patients and who responds to an alarm. In the operating room, there are also some algorithms. One of the most developed one is this one. Perhaps you have seen this article in the JAMA. Using the algorithm developed by Edwards, led to less hypertension because the anesthesiologist had more reaction when the hypertension was predicted and detected by this system. And there is a large European study led by Bernd Saugel that will show the clinical interest of such a monitoring. We have less algorithms in the ICU. But for instance, this one is interesting because the authors showed that this hemodynamic stability index predicted deterioration, and the more variables they put inside, the better was the prediction. Of course, what one expects mainly from AI is to help for making decisions. And likely the dream comes from the insulin syringes, insulin pumps that automatically adapt the dose of insulin based on AI algorithms to the glucose level. And you know that these smart pumps that are today on the market allow a much tighter control of the glucose level. And it's true that, in fact, these monitoring devices provide many variables that must be integrated and that need sort of an expertise, especially if we take into account all the variables. It's much more complicated than just glucose level. And even the experts can make bad decisions or improve their decision process, especially for guiding fluid therapy or giving norepinephrine in a better way. Again, we don't have to wait because there are some algorithms adapting the dose of norepinephrine to mean arterial pressure in an automated way. This is a closed-loop system that has been investigated here again by the team of Alexandre Houston. They showed that it reduces intraoperative hypertension, and I show this study which is very recently which has been published a few weeks ago in the ICU after cardiac surgery. It was conducted here in Erasmus Hospital in Brussels. And you see that patients spent less time in hypertension thanks to this closed-loop system. For fluids, it's a bit more complicated because you need to measure cardiac output, likely. We are working on this. But likely what we would expect at best from AI is to guide the whole treatment of shock patients, from diagnosis to complex treatments. We did not reach the goal for the moment. And as for respiratory systems, it's far from the use of such devices. But likely you've read this article in Nature Medicine by Komorowski and authors. It's a complex article, of course, but they have developed an artificial intelligence clinician that learned from many data coming from many patients from a large database. And they showed that if patients would have been treated by this AI clinician, they would have received less fluid and more vasopressors. So you see an initial step in developing something that may help treating these patients. And what's interesting is that they show that if clinicians had taken decisions close to the decisions of the AI clinician, the survival was better, suggesting that this AI clinician is good for prognosis. And there are new studies published with this device or algorithm, I don't know. And it's interesting, the conclusion, they said that in the last 15 years, many treatments have been developed without reducing mortality in sepsis, and so the use of computer decision support systems should better guide treatments and may improve outcome. This is a message full of hope. So to conclude, likely we will have some non-invasive devices or minimally invasive devices that will provide many variables, including complex variables. The challenge is that to keep accuracy, it will allow perhaps a more comprehensive analysis, especially of tissue oxygenation. Devices would be easier to use, wireless, and this will allow remote monitoring. And finally, perhaps that we will use all these devices in a smarter way to guide the treatment of our patients, but perhaps that things will be completely different. Thank you for your attention.
Thank you very much, Xavier, for this very nice presentation. It's now time to discuss, to raise questions. Anyone from the floor? Xavier, I have a question that also applies to Massimo. It's about physiology, respiratory or cardiovascular. The people who are developing such devices are mastering physiology, and we are going to bring it at the bedside with people who would get less interest in physiology, but I still consider that we need to challenge the results we are observing. So we need to strongly increase the teaching of physiology for the next generation. Can you comment on that, please?
That's a very interesting message that I heard from Massimo. Indeed, hemodynamics and ventilation, it's the same. Everything is based on physiology. And by the way, I think it's the interest of these fields of critical care. But if you use AI without a physiological brain, you come to stupid results. We observe that we work on a system, on a closed-loop system on fluids. If you speak with the engineers, they can develop something that is totally stupid and that goes at the opposite position, opposite direction compared to what you expected, just because they do not know physiology. And so definitely, but I think it's the case in any fields of AI, you need people who know how to use these devices and not only engineers. And by the way, this is what they tell you. Just explain to me how it should work. Again, the same database with different algorithms could lead to a totally stupid decision. So that's indeed very, very important.
This is absolutely the same for the mechanical ventilation and respiratory physiology. What I believe, however, and I think that things are going slightly better over the last few years, that the integration between the physicians and the engineer can get better results, but it is obvious that they need to be interpreted in a proper way and verified, validated. At times, as you well explained, they are capable to develop fantastic mathematical algorithms that cannot be applied at the bedside.
Thank you, Massimo. Any comment, any questions from the floor, any reaction? So I have another one, Xavier. We are teaching, using machine learning, an algorithm to predict an outcome that has been established in a patient managed in my ICU 10 years ago. But still, mortality has decreased in many of the ICU and critical care illness. It needs that those algorithms will be updated in new sets of data by the users. But how can we make a single algorithm able to predict outcomes at any places where we know that there is a huge center effect in many of the critical care illness?
That's really an issue. You point out two big issues. The first is the time when the databases have been constituted. And indeed, AI based on old databases, and there are many articles still in the literature, are not valid. You need really a well-collected and recent database. By the way, in hemodynamics, there is also a big problem that there are very few databases with a proper assessment of treatments that tells you this patient has received fluid. We have changed the dose of norepinephrine. So it's very difficult to analyze. First point, recent databases. And second, indeed, it should take into account what you're saying. It should take into account all the variability of these patients. And that's indeed very, very, very difficult. By the way, it points out the fact that daily we take very, very complex decisions, you know. Even changing the tidal volume in a patient integrates many, many things. Giving a fluid bolus in a patient, it's the same. So it's indeed very, very difficult. There are some demographic data that must be integrated as well and that give some very valuable information. We saw that working on fluids, by the way. So it's not only physiological hemodynamic variables, but also demographic variables and perhaps the center, as you said.
Thank you, Xavier. We are now 5 years after the publication from the amazing paper from Imperial. So who in the room is using any AI to drive vasopressors in your patients? So what is the knowledge transfer of such publications? I see no hand in the room. So we need to also overcome the barriers for the applications of this and validating at large scales And I think that us as a European community, we have a responsibility for that.
For sure. And they are publishing more and more about this AI clinician with some nice and fancy results indeed.
Thank you. Thank you. Now it's my pleasure to introduce Professor Marlies Ostermann from London, UK, and her topic will be renal failure. Marlies.
Thank you very much. Thank you, Mr. Chairman, for the nice introduction. And thank you for the honor to be here. I have to say, I feel extremely jealous. I feel jealous listening to Professor Antonelli and Professor Monnet. What they're describing in hemodynamic monitoring and in respiratory medicine is not what's happening in critical care nephrology. We are far behind at the moment. But I hope I can give you a glimpse of hope that things will improve. These are my disclosures, but they've not influenced what I'm going to say. So as I've already said, in critical care nephrology, we have a patient population that is very rich, very heterogeneous, and they all are labeled as having acute kidney injury, the syndrome acute kidney injury. We understand that acute kidney injury is a syndrome, and we also know behind the syndrome are so many different patients with different etiologies, different environment, different management, and different pre-existing burden, so genetic burden. And still we all label them as acute kidney injury. We have a good understanding now that acute kidney injury is very common and affects more than 50% of patients in the intensive care unit. We've done a lot of physiology studies and know much more about the underlying physiology of acute kidney injury, all the different various pathways that may contribute to acute kidney injury. But at the bedside, we struggle because we diagnose acute kidney injury late. When it occurs, we have no idea what happens to patients, whether they recover quickly or not. We do know that we have understood that acute kidney injury never comes alone and affects other organs and also leaves patients with problems later. So survivors of acute kidney injury have a major health burden after they leave hospital alive. They have a very high risk of cardiovascular complications, developing chronic kidney disease, and also rarer problems like they have an increased risk of fractures. And that's an interesting observation, but we don't really understand why this happens. And the main problem is that we have one biomarker in routine practice to describe all these hundreds of causes and types of acute kidney injury, and we measure it very often just once a day. And I think that's the problem in critical care nephrology, and that this has caused where we are now, that we have no therapies, we have very inadequate tools to predict who will get acute kidney injury, and we have inadequate tools to predict what will happen. But I put it to you, there is hope. And there is hope because a lot of people across the world have done amazing physiology studies, try to understand better what happens in acute kidney injury, and importantly, try to understand whether we unpick this big syndrome and find interesting subtypes, learning what colleagues particularly in ARDS and in cardiovascular disease have done. So if you go back to some nice physiology studies at the moment, this term molecular nephrology has evolved, which has taught us that different etiologies elicit very, very divergent responses at multiple levels. So for instance, if you do experiments in the laboratory and induce acute kidney injuries through various different means, so hypovolemia or clamping of the renal arteries or giving animals some toxic stuff that causes tubular toxicity, different metabolic pathways get activated, different immunological pathways are activated or inhibited, and different genetic genes are expressed and activated. And this has helped us to understand better why acute kidney injury occurs, and it will certainly help us to see whether we can find therapies and which pathway to target. And it may explain why certain therapies in clinical trials were unsuccessful, because they just targeted the wrong thing. When you look at these trials in these laboratories, then the other amazing thing is that when they looked at genetic activation, there was less than 10% common gene activation between all these various experiments. So AKI is just a very heterogeneous problem. Now, if we think, well, let's just look at one type of acute kidney injury. Even if you think of something like AKI in the context of sepsis, which has been studied a lot, we now have to recognize even that has multiple different subphenotypes. And we know this now from the physiological studies that have been done. We now know that patients who get sepsis, different patients will have a different primary underlying pathophysiological process triggering the subsequent development of AKI. And there are different underlying pathways between different patients, and this probably explains why we have so many different endotypes of sepsis-associated AKI. Obviously, on top of that, we have the impact of the medical behavior, so what we do to patients, the way we treat them, the antibiotics we choose or not choose, the type of fluids we may give, and the other things, the hemodynamic management or the type of ventilatory management, the PEEP settings, for instance. And all of this explains why at the bedside patients are so different, why we have so many different phenotypes. And when we measure them in research studies and, for instance, look at new biomarkers, they differ completely. So the biomarkers can tell us sometimes can tell us what the underlying etiology was and how prognosis may evolve. Now, we're not short of biomarkers. I said at the bedside, most of us in the world use creatinine, and most of us measure it once a day. But from the research conducted so far, we know there are so many. There is a large number of peptides and substances that are released by the kidneys in response to a nephrotoxic insult. And they get released from different parts of the nephron, and they tell us different things of the story. They may tell us the underlying etiology, they may tell us the anatomical site, or they may give us information about the likelihood of recovery or progression. And they're fascinating, and they can be measured, but they're not suitable and affordable for routine clinical practice at the bedside. But obviously there is hope, and I am very hopeful that we will at some point use some of them to characterize acute kidney injury better, to see whether we can get better information about the underlying etiology so that we then study the right people for a potential therapy. And that we also hopefully at some point find tools to give us more information about identify those who are likely to progress, who may be suitable for potential intervention, and those who are unlikely to deteriorate and are likely to recover fast, in which case we just don't need to intervene. And heat maps like this have been constructed where obviously, as we learn more about acute kidney injury from these studies, and we also better understand the underlying genetic predispositions, the underlying molecular nephrology, that at some point, again, with physiological studies and the help of AI and advanced statistical techniques, we can identify subtypes of AKI and identify those who are most likely to respond. Clearly, we've learned in critical care nephrology that the kidneys never work alone. Acute kidney injury and kidney function depends on all the other organs. So whatever we decide and learn in critical care nephrology will be impacted by developments in other organs, in particular, obviously, cardiovascular, hemodynamics, and pulmonary disturbances. And so any form of precision medicine in future will incorporate the kidney together with all the other organs and the messages and information from these organs so that we in future target the right therapies. And I'm hopeful that if we use this information and identify subphenotypes of AKI, that we will also identify particular therapies for subgroups of patients with a particular type of AKI, so that these therapies target the main pathophysiological process. I'm coming to the end of this talk, and I was extremely jealous listening to Professor Monnet, and this concern about spaghetti and cabling is not a problem in critical care nephrology. We have absolutely no monitoring of kidney function. All we have is a creatinine And then we measure urine output, but we know that urine output is a very non-specific marker, and we can easily manipulate it. But again, there is hope. And there are companies and there's very promising studies showing that it is now possible, hopefully in future, to measure glomerular filtration continuously at the bedside. So we already do, we measure oxygen saturation, we measure patients' blood pressure, we have a continuous heart rate on the monitor. And at the moment, what's missing is clearly some continuous monitoring of kidney function, continuous monitoring of glomerular function. And with these tools, it appears to be possible. They're very promising. So essentially, they work by injecting a particular marker that is cleared by glomerular filtration and acts as a dye and can then be detected through these small devices transcutaneously. And when measured and when when tested in clinical trials, these simple devices worked as well as the gold standard in critical care nephrology, which is the iohexol GFR measurement. And as you can see here, it's a fantastic correlation. And these relatively small devices are now being tested in clinical trials, and I really hope that they will perform as well as in these initial studies, and in future provide us as a tool to allow us to monitor kidney function immediately at the bedside. So when we do something and give a potentially nephrotoxic drug, we can see how it acts on the kidneys. If we give a vasopressor, then we can hopefully monitor and see whether it affects glomerular perfusion and glomerular filtration immediately. And lastly, clearly I couldn't give this talk without referring to AI. There's a lot of hope that the advances in augmented intelligence and telemedicine will also reach the group of critical care nephrologists who are very keen to get better tools to predict acute kidney injury and better tools to identify patients who are likely to deteriorate and may benefit from interventions. So I'm hopeful that we move from the current approach where everybody with AKI, the syndrome AKI, gets managed according to an agreed consensus guideline, and move more towards the approach where we are able at the bedside to identify subphenotypes of acute kidney injury, where we have information about the underlying etiology, the likelihood of treatment response, and then treat patients accordingly. So with this, with all the information from the existing research conducted and also what we've learned from other specialties, I'm hopeful that we will get there, mainly with the aim to treat patients who will benefit from treatments and identify those who are likely to come from harm from things we are doing at the bedside. So I'm hoping that the future will be bright in critical care nephrology. Thank you for your attention.
Thank you, Marlies. Excellent presentation. Now we are open to questions from the floor. One from Massimo.
Marlies, thank you very much for this wonderful presentation. I want to ask you something that maybe is a bit collateral to your presentation. You know that nowadays one of the big problems that we are focusing on is the resuscitation of patients who are affected by septic shock, for instance. Do we have any clue that, for instance, an earlier adoption of continuous replacement therapy may be effective or should be indicated in these circumstances in early phases?
It's a very good question. So if I understand the question correctly, we now, it refers to de-resuscitation and avoidance of fluid overload, I assume. We have learned with experience that giving too much fluid is obviously harmful for all the organs, for the body, but in particular harmful to kidney function. So the kidneys and the brain cannot expand. So the brain has a skull and can't expand, and the kidneys have a very tight capsule. So in situations where patients get too much fluid and become fluid overloaded, the kidneys can't expand, the kidneys swell, and intrarenal pressure goes up and can directly lead to acute kidney injury and can also hamper recovery. So for the kidneys, de-resuscitation is essential and is actually a means to improve kidney function. And ways to de-resuscitate congested kidneys would be to give either diuretics or to start CRRT early. Now, take fluid off through CRRT. So at the moment, the trials have not shown an improvement with earlier initiation of CRRT, even in those who were had a higher fluid balance at the time. I would put it, I think we have to go further and avoid the fluid overload, spend much more time on also avoiding congestion within the kidneys, carry on focusing on the CVP again, because the CVP correlates with the pressure within the renal vein. And if you see a high CVP, it gives you really good information that the pressure within the renal vein is also high and may contribute to renal congestion. So my plea would be to go back to physiology, interpret the clinical science which we already have at the bedside. And then lastly, I want to add the saying early initiation of renal replacement therapy has not been shown to be effective in this scenario. And in fact, there is evidence that it's actually harmful. So in the START-AKI trial, which was the largest trial to date and had sufficient information and sufficient data to do these detailed sub-analysis, in this START-AKI trial with 3,000 patients, those randomized to early initiation of renal replacement therapy had a significantly higher risk of still being dialysis dependent at 90 days. And that means these patients were rendered chronically dialysis dependent. And that's a major impact on patients' quality of life, but also their prognosis, health prognosis, because it is associated with many other health problems. So sadly, no, it doesn't help.
Okay. Yes, thank you very much. Didier Dreyfus from France. I'm almost a clinician, and although I try to do kind of research on acute kidney injury, you showed, and it has been shown for many, many, many years, but there are plentiful of biomarkers. But why don't you conduct any randomized controlled trial to see if they add anything to clinician judgment according to very simple clinical condition? Because do you wait for having 100, 200, 300, 2,000 biomarkers, and then which one will you choose to do a randomized clinical trial, or will you never conduct any kind of comparative trial?
Thank you, Professor Dreyfus. First of all, thank you also for your participation in START-AKI, which gave us these results on early and late initiation. The question is
beating a kiki also.
correct, but it's a really good question. So, but in fairness, there have been randomized controlled trials. We have had 4 randomized controlled trials using biomarkers to stratify patients and to guide management, where the biomarkers were used to identify patients who had early signs of acute kidney injury. And in fairness, the Prevaki 1 and the Prevaki 2 study looking at biomarker-guided management in patients after cardiac surgery showed that this strategy prevented severe acute kidney injury. And the Big Pack trial, again, used biomarkers which indicated early acute kidney injury before the creatinine was up, and then allowed the randomization to particular arms, again showed less severe acute kidney injury and some cost saving and other things. So if you choose the right biomarker and the right intervention in the right population, then they have been shown.
Yes, but the problem in all randomized clinical trials is mainly mortality or renal replacement-free days, and not only having less or more acute kidney injury. In the preliminary study of START AKI, they tested NGAL and realized that it was of no use. So maybe the next one will be. But in my opinion, we should have patient-centered outcomes in randomized control study. The patient who has a little bit more AKI and who survives and recovers the same renal function than the one who had a less severe AKI as judged by biomarkers, who cares?
Well, the big pack and Privaki study did show less severe acute kidney injury. So I do care about that. I think patients also care about whether they have mild AKI or severe AKI.
Thank you.
Just, we have been, one question. We have been using, fluid challenge, furosemide challenge in AKI, but it has been said that the new ultrasound, which can see the pre-renal, post-renal circulations, it's operator dependent definitely, and it's not. But in future, do you think that that kind of ultrasound will be available to everyone so that we do not give extra fluid or extra furosemide in future to tackle AKI?
Absolutely. So experts in renal ultrasound and ultrasound sonography show really impressive results, and they can show a congested kidney, they can show over vasoconstriction. But it is extremely operator dependent, as you said, and it takes a lot of time. But I'm jealous of people's skills who can do this. But at the bedside in routine clinical practice, it's currently impractical. But I'm hopeful again that the technology improves, makes it easier, and that, again, the technical support. And that would, yes, in the right hands, we can detect a kidney that is swollen and congested. People can even detect over vasoconstriction of various blood vessels. And that would be beautiful if we could have this at the bedside. Absolutely.
Thank you very much, Marlies, and thank you for raising so much discussions and controversies, saying that your presentation was bright. And it's my pleasure to introduce Professor Menon now for the future of TBI management.
Thank you very much, Elaine, Claudio. So this will be a slightly different talk from the ones you've heard. What I'm trying to do is to cast the net a bit further forward, 5 years or so, and see what therapies we might be using in the ICU, not so much the process of management as we have now. So it consists of two things. One is which targets and which patients, and the matching of patients to targets is absolutely critical, the precision medicine story. But I've addressed which patients in several previous talks, and prevent me and the rest of the audience from getting bored, I'm not going to address that some more. As far as which targets are concerned, well, the first set of targets is those that we're using now, but we'll shift from responding to physiology to modulating underlying biology. What do I mean by this? So the current management of intracranial pressure with brain tissue oxygen monitoring is probably best summarized using the CIVIC guidelines that are here. But the problem with this is that it primarily uses interventions that respond to a rise in ICP with variable effects on control, but does not affect the underlying mechanisms. What we would like to do is to prevent the biology that leads to these things. And there's increasing interest in developing drugs that prevent or reverse the molecular mechanisms that lead to ICP rise. And there are three classes or three drugs that are currently under trial and worth talking about. The first is using glibenclamide at the sulfonylurea receptor. The combination of the SIR1 receptor and the TRPM4 channel is an integral part of contusion expansion and pericontusional edema. And Biogen are conducting a phase 2 trial looking at the effect of this. This is dependent very heavily on some outstanding work done by Mark Simard and Ruchi Jha, the first and last authors on this review article. The second is looking at neurogenic inflammation driven by substance P and the NK1 receptor. And this is work that has emerged from Australia from Bob Wink's lab, being run by Procura Neuro. And this is also in phase 2 trials and would use inhibition of neurogenic inflammation to reduce ICP by preventing edema. And finally, Lantmanen, who is primarily a food company, they advertise themselves as from field to fork, but have a compound called anti-secretory factor, which is salivum, which is actually currently marketed as a food supplement. And they are running, there's this protocol for a food supplement trial, but they're also going to do a formal phase 2 trial. And both of those, I think, would be interesting in terms of the results they produce. So watch out for these 3 compounds and similar classes of compounds. The second thing that we will probably see a lot of, and this has been given an impetus by COVID, is modulation of the innate and adaptive host response at early and late time points. So there are a whole host of drugs that are being used or have been used either in TBI or in other conditions which are candidates here. There are cytokine and other mediator antagonists, inflammasome inhibitors, statins, minocycline, histone deacetylase inhibitors to look at epigenetic modulation, nanoparticles, and then a whole range of drugs that have been used really as immunomodulators in neuroimmune disease. And it's useful to classify these. Those that are in green are in trial in TBI. There are others that have been used in TBI routinely. So both melatonin and propofol and valproate are used conventionally in our patients every time. But both melatonin and propofol have a role in inhibiting the inflammasome, and valproate is a histone deacetylase inhibitor, so may be able to modulate epigenetic changes. The ones that are in the sort of orangey color are drugs that are used in other indications. And the great advantage is that their safety is well recognized. We know what they can and can't do, but their application to TBI in terms of repurposed drugs may be something to look forward to. So the question that when I talk about this, people come and say is, but we've tried inhibiting inflammation before and it hasn't worked. Why should it work now? And this is the CRASH trial, final results showing that not only did it not work, it caused harm when used in high dose. The point is that this was a pragmatic trial. Its great achievement was organizational, but it was rather naive in its terms of its biology, using industrial doses of steroids with no attention to blood sugar, no attention to adrenal suppression as a consequence later on, no attention to the increased risks of infection, is not an approach that you and I would have in our intensive care units. There's no requirement to give these people a PPI or a H2 blocker. And finally, we also have currently better understanding of the pathophysiology and side effects, and blood, biofluid, and imaging biomarkers, and we can use precision medicine approaches to match patients directly. So as an example, this was a phase 2 trial that was conducted from Cambridge by Adele Helmy. We've known for some time what the profile of cytokines is. Microdialysis catheters go in to measure lactate pyruvate ratio as part of clinical care, but by using 100 kilodalton cutoff catheters, we also get access to biomolecules. And we know the various mediators and what time points after the injury they emerge, and that provides a rational basis for using a drug, in this case, anakinra IL-1RA. And we can, first of all, make sure that the drug gets into the brain. And you can see the blue bars are the endogenous IL-1RA and the red bars are the treated patients. There's a lot of variation between subjects, but you can actually demonstrate that the drug gets into the brain. You can then see what effect it has on the overall cytokine pattern by undertaking a principal component analysis. You can isolate which cytokines are being affected. And then you can ask whether this has an effect on lesion expansion, here using MRI and showing that lesion expansion has this particular time profile. And we can ask the question whether these drugs, all of the anti-inflammatory drugs I talked about, make a difference, or more directly look at neuroinflammation using PK-1295 PET. Now, this is not going to be part of our clinical care paradigm, but what it will do is allow us to select drugs for big phase 3 trials that are much more likely to succeed. And I think that pathway is something that we will explore. So much for things that you put in via an injection, but you can also put in cell therapies. And here, there are a whole host of things that are emerging. There are issues regarding what mechanisms, whether there's a common effect, whether it's modulation of neuroinflammation and microglial phenotype, or do they actually engraft and replace the dead cells? Do they produce neurotrophins locally? Is there modulation of systemic inflammation, whether you use autogenic or allogeneic cells with or without modifications? Most of the clinical studies so far, and I'll describe that in just a minute, have used either allogeneic umbilical cord mesenchymal stem cells or bone marrow-derived autologous cells. But there's also interest experimentally at this stage in using embryonal stem cell-derived cells, and also the products of cells, so exosomes and cell-derived proteins. So Mike Chop's lab in the States has done an awful lot of work looking at exosomes, and I think we should watch that space. So what's happened clinically? Well, the studies that have happened so far, there are 6 studies in the acute or subacute phase, which have included 135 patients in open label, but also 1 RCT of 15 actively treated patients and 5 controls. There's also been quite a lot of studies in the chronic stage, weeks to months after injury, and these are have included 64 open label patients and 101 patients in RCTs, 66 of whom have been treated with active treatment. And they've used a mix of autologous bone marrow-derived stem cells and umbilical cord mesenchymal stem cells. These have generally been shown to be safe. There may be a possible signal of efficacy. The Fugl-Meyer scale is a motor scale looking at limb recovery, but also Glasgow Coma scale in the most severely injured patients. And that may be a population, the patients who don't wake up and have very little to lose, may be a population where we'll use this perhaps earlier than otherwise. But there's difficulty disentangling the natural recovery from the treatment effects, but there's more sophistication there. I'll just make the point there are also attempts to increase endogenous mechanisms for repair, and many of these stem cells that you see, endogenous stem cells, come from the hippocampus or the subventricular zone, but there are also astrocytes which can actually regress to form stem cells, and ways to actually cause endogenous stem cell production may actually facilitate repair. This seems a bit like science fiction, but I'd refer you to these 2 papers. The first is a paper which essentially covers this, and then the slice, more perspective article says who, when, where, and how we would use stem cell therapies in TBI. And indeed, there is a study that's going to start, run by Giuseppe Citerio and Elisa Zanier. Giuseppe is from Monza, and many of you will know him as the editor-in-chief of Isicem, and Elisa works at the Mario Negri Institute. There's been data suggesting that mesenchymal stem cells are helpful in neurological injury, and then they've been used in other conditions as well, these brown boxes down there. The first experiment at the Mario Negri Institute was a long time ago, 15 years ago now. But now they have funding from local funders to undertake the matrix study. The primary outcome is safety of mesenchymal stem cells administered IV within 48 hours of TBI at a dosage of 80 or 160 million cells. And second, to see whether there's a change in biomarkers. You remember I told you we have better biomarkers, and here NFL has been chosen. So this is a concrete study. This is something that is coming to an intensive care unit within the next 12 months, and many more of these will be coming to your ICUs with the prospect for repair. The other thing that's emerging now is the realization that you can get quite early neurodegeneration, which carries on to weeks and months after TBI. So here are data from our group showing that if you compare 6 months after TBI to maybe 5 years to 10 years after TBI, there's volume loss in the brain. The brain looks older and continues to age in an accelerated fashion. What are the underlying mechanisms? So this is again a PET study from our group in TBI with patients within 48 hours of TBI and then going all the way up to 1 year. So this is not new. We have known for a long time that traumatic brain injury results in amyloid deposition in the brain in terms of plaques, exactly the same chemistry that you see in Alzheimer's disease, probably because the axons are torn, amyloid precursor protein is spat out, the secretases work on it and produces too much amyloid. And because it can't be cleared by neprilysin, that gets overwhelmed, they form plaques, and they have acute effects. They're neurotoxic, they change vasoregulation. And you can see that they're there within a day or two in young people after TBI. So interventions to try and address this may be useful. Similarly, we know that inflammation is there acutely. I showed you the PK1295 image of the acute phase. This is work from Imperial College, Dave Sharp's group, showing that it persists up to 17 years afterwards. And modulating inflammation in the early stage may prevent late inflammation. So this is a target that keeps on giving over time. And also tau deposition can also happen and can carry on for long periods afterwards. The problem, of course, is this. Not all patients with TBI show evidence of neurodegenerative pathology, and I've shown you advanced MR and PET techniques, but these are expensive and logistically unfeasible. But there are blood biomarkers that are emerging based on phosphorylated tau. For example, we've shown that p-tau181 is elevated at late points in a subset of patients, and amyloid A-beta 40-42 ratios. And conventional biomarkers such as NFL are persistently elevated at 6 months, and they predict subsequent volume loss. So why is this important for me as an intensivist? Because that is a process that's initiated while the patient is in my ICU. And there are things that I can do to prevent that progressive inflammatory insult from progressing. And once we find that these things are important, there are a whole host of drugs which we don't have to actually devise, because the dementia field has got tens, hundreds of drugs that are coming, many of which are disease-modifying drugs. Here in this analysis, the green chunk here is all disease-modifying, which includes anti-tau, anti-amyloid, and anti-inflammatory therapies. And these are drugs that we can take to our practice. We have to be a bit careful. For example, lecanemab and aducanumab, those are the two new monoclonal antibodies that have been shown to clear amyloid, but they have a small incidence of ARIA. This is local edema and hemorrhage associated with clearance of the amyloid. And in someone who has a tight head, having that would not be a good idea. But there'll be other compounds that come along which have fewer risks, and we really need to think about those. And finally, we'll need to think about arousal therapies and poor outcome. In the other talk I gave earlier in this lecture theater, what I showed was this paper of now 10 years ago from Joe Giacino, showing that amantadine, because of its presynaptic and postsynaptic dopamine agonist properties, can accelerate arousal. We don't know whether it eventually increases the number of people who are recovering from coma, but it can accelerate recovery from coma. But there's a whole host of other drugs and interventions, transcranial direct current stimulation, depth electrodes, a whole host of other interventions pharmacologically that can be used. And I would encourage you to read this nice review from Brian Edlow and colleagues, which covers some of those. So just to summarize, there are a lot of new interventions that are coming your way, and you may choose to use in your intensive care units in the TBI patients over the next 5 to 10 years. And we also have, as has been covered in previous talks in this conference, ability to identify patients who would be most suitable for these drugs based either on the severity and prognostication, or selecting endotypes based on their biology in that individual. And this, I think, is a combination that is more likely to succeed than our approach of using very non-specific drugs very widely across the patient population. And we should watch the space. Thank you.
Thank you very much, David. We have time for one question, if any. Comment?
I have a question. Many questions, actually. Great talk. I've been surprised reading recently that patients with traumatic brain injury can have increased levels of biomarkers several months after the injury. So probably they have a chronic evolution after intensive care. Is there any way to use biomarkers to treat these patients differently? Possibly with treatments like aducanumab you mentioned, to reduce the processes that may cause a late deterioration of their brain?
Yeah, so I think that the most attractive option really comes from a lesson we've learned in transplantation. We know that the alarmin response when organs are transplanted will result in amplification of the adaptive immune response. We've shown that after traumatic brain injury, but after COVID, after influenza, the body produces a whole range of autoantibodies. So that acute inflammatory insult can not only cause acute inflammation, but can cause initiation of acute innate inflammation, but also predispose to adaptive inflammation. And if we can damp down the acute inflammatory insult, that alarmin response, we may be able to reduce some of the issues at later time points. And I think that's a very attractive option. So there are, these are theories, they require studies and protocols, but I think over the next 5 to 10 years we'll be seeing them.
Thank you. Thank you very much. Now it's my pleasure to introduce David Grimaldi, Professor David Grimaldi from Brussels, Belgium, and the topic will be a very intriguing one, any impact of a climate change for the intensivists. Please, David.
Mr. Chairman, dear colleagues, thanks to you which stay in the room. I apologize because I'm afraid I will break a little bit the mood of this session, but we can discuss it at the end. I have no conflict of interest relating to this presentation, and I will try to explain to you why intensivists should interest in climate change. So this graph shows you the mean surface temperature of the 20,000 last years on the surface of our planet, the Earth, and it gives you 3 information. First, last deglaciation corresponds to a warming of 4 degrees. This is the same amount of warming that we are expecting for the next century. This warming had induced some changes on the land, and just to give you an order of magnitude of these changes, we can say that 20,000 years ago, the north of Europa was under ice, 3 kilometers of ice. Sea levels was 150 meters lower. So UK could not leave Europe. It was linked to us. The second information is that since 10,000 years, the climate was stable. And if the climate is stable, you know when you can farm. And this was the period when humanity go to farming, settlement, create cities, and finished in the Isicem symposium in Brussels. The third information is that the warming we are observing has a very much quicker rate than a natural one. You can see that, and it has a very big consequences. Trees, flowers will have some difficulties to migrate and to adapt because they are migrating slower than animals or human. Okay, basically the mechanism of warming is very simple. We are emitting greenhouse gases. These gases reflect infrared radiation. It's a chemical property. And this reflecting infrared radiation increases the temperature at the Earth's surface. You can see here the concentration in carbon dioxide in the atmosphere, which is climbing since the second half of the 20th centuries. And for the IPCC scientists, there is no doubt that this is this human activity which creates the global warming. The second bad news is that carbon dioxide has a long half-life in the atmosphere and will stay there for decades and even centuries, meaning that the warming will be directly related and proportionally related to the amount of carbon dioxide we will have emitted in the atmosphere. So these are the data from the IPCC scenarios. You see here 5 scenarios. These are emission scenarios. The blue one are very low emitting scenarios, allowing to respect the Paris Agreement. The yellow one is the scenario if all the governments in the planet has respected their engagement at the different COP. In this case, the warming will be 2.7 degrees. It's an estimation for sure. And the red one is the actual course of warming. So let's see what is a world with 4 degrees warming. For sure, there will be heat waves. But you have seen that warming will be proportional to the emission. However, the consequences will have an exponential relationship with the warming, with the temperature rise. And for instance, a heat wave that occurs once every 50 years will occur 40 times every 50 years. Meaning, for instance, that the big heat wave of 2003 in Europe will be a normal summer, meaning that summer won't be anymore a very pleasant season. It will be more frequent, it will be hotter, 5 degrees hotter in mean, and for sure we can expect to have more patients with heat stroke in the ICU, but I'm not sure this is the point you should retain. Heat wave will induce drought. Drought will be exponentially more frequent. This is the same phenomenon in specific regions like Mediterranean Sea, like Australia, like South Africa. But other regions will have heavy precipitation because water will evaporate from the seas. This is, for instance, the case for India, and there will be disastering flooding related to these precipitations. We experiment that in 2021 in Belgium with a 4 billion euros damage catastrophe. Sea levels will rise. This will be a very long phenomenon, so maybe we won't be too affected by that. It's more our children or grandchildren. It's very unclear and there is a lot of uncertainty, but it could lead to a rise between 3 and 7 meters of the sea level, meaning that New York will be flooded as well, Amsterdam, Anvers. And there are some unlikely scenarios, but that the scientists cannot exclude, where the west part of the Antarctic will thaw, leading to a very rapid increase in sea levels up to 15 meters in 2300. Last but not least, heat and humidity combined will lead to the human species to be unable to live in some place. When the temperature is over 35 degrees, too cold, we are swelling, but if the humidity is 100%, you cannot swelling anymore, and this paper that came out in Nature shows you the number of days that along the year we will have some conditions that are incompatible with human life. And in the worst case scenario, you can see that all the equatorial belts will be unlivable all the year, basically. And these are areas with a lot of people, and we don't think that they will stay here. So IPCC shows also the actual sanitary consequences. This graph is a little bit difficult to understand. If the sign is a minus, it means that the impacts are increasing, the adverse impact is increasing. And if it's in dark blue, it means that science is very confident that this is due to climate change, more than 90% confidence. And you can maybe not see, but I can tell you that heat and malnutrition is increasing, mental health is deteriorating, displacement increase. For infectious disease, it's less clear at that time. The IPCC report also highlights that there will be social consequences: food insecurity, water scarcity, famine, massive migration that will threaten our societies. One specific point for intensivists is that we have to expect damage to infrastructures like our hospital. So a nice hospital at the beginning of the 21st century will have to prepare to flooding if it is near a river or a sea. We have to cope with big heat wave, maybe with cyclone or tornado, which are difficult to predict, wildfire, in the same time that all the people that are victims of this event will come to the hospital to be healed. We have already some example in the world. At the left part, this is an hospital in white in Australia, threatened by a bushfire. On the right side of the slides, this is a Norwood Hospital in Boston that were flooded in 2021. I wanted to show you the videos, but it does not work. I invite you to get to YouTube and to see Norwood Hospital flooding and see what is a flooding in the basement of the hospital. There were 100 patients here and they were all evacuated successfully. Climate change means change, not only warming, and there will be instability and strange manifestation, like cold outbreak that will be more frequent. For instance, Texas endured in February 2021 a huge cold outbreak with minus temperature lower than usual, something like 7 to 8 degrees in the Celsius scale. And you can see here that the nurses could not get in car to work, so they have to walk. You can see that hospitals were running out water and power, and we may think at how to do ICU in this context without healthcare workers, no powers and no water. This is not David Grimaldi that say that, this is the WHO. And the WHO released in 2021 this guidance for climate resilience for healthcare facilities, insisting on 4 critical points: the workers, the water, the energy, the infrastructure. I don't have time to detail, but I think all our CEOs in the hospital should have read it, but I doubt about that. So, I have just a little time to talk about what we can do. You have understood that the more we will emit, the more the disturbance will be, and the adaptation will be very hard. So it's a clear necessity to mitigate our emission. And mitigate our emission means to decrease the fossil fuels consumption. This graph shows you the primary energy consumption in the world since the 19th century. We have increased the energy consumption a lot. You can see in gray the coal, in blue the oil, in purple the gas, and you cannot see wind and solar energy, which are on the top very little. These are data from 2020, just before COVID. 80% of the energy we are consuming emits carbon dioxide. And we will have to decrease that as well in the healthcare system, because we are using machines that use energies all the days for sterilizing, for food, for pills, for devices, and so on. So the healthcare system is an emitting sector. The Lancet Countdown estimated 2.7 gigaton. This is 5% of all the emission worldwide. Like the buildings, for instance, it's the same amount, roughly half of all the transport in the world. And we have some data in the ICU. There are coming data, and I think there is still uncertainty. But for instance, in this US ICU, one day in one bed emitted 150 kilograms CO2, so roughly 6 beds per day, 1 ton. These are US data where power is very carbonized, and power is there in the yellow part, but you can see that the most emitting part of our care is consumables, equipment, meaning that this is our work, which is questioned by that. As intensivists, we are specialists of the emergency, and I always laugh when I heard the climate is an emergency, the emergency. So, no, I am the specialist of emergency. We are, so we know what is emergency. Until I saw this graph, and I understood that given the long half-life of carbon dioxide, we have to decrease the emission, but we cannot stop them from one day to another. So we have to decrease them progressively, meaning that we'll still emit during the decrease. And you can see here that if we have begun in 2000, we could have adopted a rate of 2% of decrease per year. That's not what happened. And now we must adopt a rate of 5 to 6% of decrease per year to achieve, to stay below the 2 degrees warming. Is this easy to decrease 5% of the greenhouse gases emission? Yes, this is easy. We did it already, but once, only once since 1950. It was in 2020. It was due to COVID. And what I'm saying here is not that we should get to the emission of 2020. I am saying that we should decrease from 2020 each year with the same amount from 2019 to 2020. So we can say we must add a COVID each year after the previous year in the emission. That is a 5% decrease per year. So you are thinking, this is not possible, this won't happen. I quite agree with you. However, whatever you think, whatever you want, it will happen. Because fossil fuels are not renewable. It makes millions of years to make fossil fuels, so they will, nonetheless, there will be a loss of fossil fuels, and the first to be shortened will be oil. We are expecting the peak oil in the following years. In Europe, we don't have oil anymore, and we have estimation that we will have half of the oil we get now in 2050, and the recent news in Ukraine shows you that it's not very good to be dependent from oil nowadays. So there will be less energy, it will be less controllable because renewable energy has not the same property that fossil fuels. It will be less stockable, and we will have to cope with that, and I think more with that than AR. And I conclude to say to you, dear colleagues, that ICU will tackle planet boundaries as the rest of our societies in the very near futures. For sure, adaptation plans are required, but in the same time, we have to make the decarbonation of the healthcare systems our priority. Otherwise, we will stay, as the Lancet says, at the mercy of fossil fuels. And with that, I thank you for your attention.
Thank you, David. Thanks, great stuff. And very concerning as well. Yeah, are there any questions from the floor? If not, I have one comment and one question for you. My comment is, when I learned that my ICU has the same carbon footprint of a 70 people condo in Rome every day, I was really, really concerned. And it's much more, my ICU is much more expensive to live in than a standard condo, definitely. Do you think that there is a way out about concerning the increasing emission? Because unlike our patients, we cannot ventilate our planet. So a very important message from your presentation is that the CO2 we emit is going to stay and will not be eliminated before centuries. And so the process is almost irreversible. What do you think will be the best way to go in the near future?
The opposite at the actual. So no, I think we must first prepare. And prepare means resilience, but I prefer the term robustness. So we must prepare to that. We must decrease our emission. We must advocate for emission decrease because physicians have a social role to play in that. And to prepare to a world that will be harder than now for the 30 years to come. And it's psychologically hard to do that. We lived in a wonderful world, in a magic world since 40 years. And now we have to prepare a decrease in the progress, a decrease in the development, crisis and crisis. But once you have accepted this, you say, okay, I must adapt to that. This is a new reality. And we will face as human beings as we always did. But we must accept that and then have more sobriety. There is no other issues. These are physical laws. We cannot, in a limited planet, increase and increase and increase our consumption of everything. So the only way is sobriety. And we must think, and we have some time, some years, to think what is sobriety in the ICU, how we will manage this, where can we make some efforts, what should we keep, what should we not, and so on.
Yeah. I would like also to ask a question to you and the public. Have you ever seen in the last few years an increase of tropical diseases that you are not prepared to treat? because at least we had one case or one person coming from Central Africa in an area which has been desertified, and she immigrated illegally in Italy and took a disease that we are not prepared to treat because it was a tropical disease. So, did you ever had this experience? I'm thinking of Brussels, which is a center of immigration, as many larger European cities.
Thank you, Claudio. This is a very important question, and it will be a social issue for sure in the following decades. We have not this experience in our ICU. I have a friend working in the migrant healthcare centers, and they were short of anti-pediculosis treatment. You see, ivermectin. They were short of ivermectin because they were an efflux in migrants. So this was of concern, and they have an epidemic waiting for the drugs. In France, they endured this summer in the south of France the first dengue epidemic with more than 60 cases, I think, Eddie. I don't, correct me if I'm wrong, but it was the highest number ever seen of dengue in France. Usually it's 3-4 cases per year. And this year with the heat wave, they had 60 cases. So it will come for sure. The Aedes mosquito are migrating north, and they transmit dengue, chikungunya, Zika. So this will certainly be disease in the Europe in the decades to come.
Yeah. There was alarm for West Nile in Italy, for instance. I was a bit surprised to hear that. We haven't seen no cases, at least in my region, but anyway, there was concern about this. Okay? Are there any questions from the floor? Just one question, please. Go ahead. Can we provide a microphone for that guy, please? Thanks.
Yeah, thank you very much for your excellent talk. I was wondering if any one of us is busy making our care in the ICU already more sustainable.
Yeah.
Yeah?
Yeah.
Well, let's start a European movement
Yes.
that we can collaborate. I talked to Jan de Wale yesterday, and he's also interested in starting this new direction because the problems are imminent and our solutions are there, but not shared on a European platform. So I was wondering if any of us is... Yeah. 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 Well,
Thank you for your comments, but yes, things are moving faster and faster, even if it's a little bit under the surface from now. But I can tell you that 60% of the New Zealand ICUs have sustainable green teams. 60%. So, okay. 20 or 30% of the Australian ICUs. So they are the pioneers, and they have edited a guide to decarbonize ICU or begin to decarbonize ICU. And the second country to look at is England with an NHS, which is far away from us, measuring carbon footprint since 2007, if I have a good memory. So England is on the move, Australia and New Zealand is on the move. France is actually moving now quickly. So there is more and more teams. And I agree with your proposal for sure.
Yeah. I'm from the Netherlands and also happy to join. Yeah. And there's a lot of things going on in the Netherlands on this field. Yes.
Now that's a call for action.
Yeah.
Well done.
Maybe you can start a